So we're just going to talk a bit about antibiotics and the antibiotics we use on the neonatal unit. Please interrupt me as I go along if you have any questions. I have tried to set my two screens up so I can see your hands, but I can't promise I'll be watching. So just pipe up if you want to ask a question. Okay. So, do you see this slide with early onset sepsis on it?
Yep.
Okay, cool. Fine. So we talk about early onset and late onset sepsis, as you probably all know, the reason why we kind of divide sepsis up into early onset and late onset is where the babies get their infections from. So early onset sepsis is predominantly a vertically acquired infection derived from the mother during pregnancy or delivery. Late onset sepsis in the context of the neonatal unit is almost always a nosocomial infection acquired while on the neonatal unit. So as I'm sure you all know, babies on the postnatal ward get cefotaxime. I mean, that is actually against the guidance within the NICE early onset sepsis guidance, but as you all also know, we don't follow the NICE early onset sepsis guidance here anyway because of the because we use the Kaiser sepsis risk calculator, which I'm not going to talk about. I'm sure you've either had Bitesize teaching about that already or you will do. But we've made the judgment here, as have many places, that the risk of giving gentamicin on the postnatal ward outweighs the downsides of giving a broad spectrum antibiotic like cefotaxime in large amounts on postnatal ward. And it's particularly safe now that we give so much less cefotaxime on the postnatal ward since introducing the sepsis risk calculator, I think. So as you know, early onset sepsis we use benzoyl penicillin and gentamicin. I think it's just worth noting that if you're considering listeria as a cause of early onset sepsis in an unwell baby on the neonatal unit, you may consider giving amoxicillin rather than benzoyl penicillin. Can anyone tell me what might make you suspicious of listeriosis in the newborn period?
Meconium in a preterm baby?
Yeah, I think that's probably the most common reason given for starting amoxicillin. And I mean, fortunately enough, it's likely that benzoyl penicillin is adequate treatment for listeria. Actually, I think most microbiologists will say that once you've proven a baby to have listeria, you should change to amoxicillin. But benzoyl penicillin has adequate activity against listeria to be a useful starting point. So I wouldn't worry too much if you're entertaining the idea of listeriosis if you start a baby on benzoyl penicillin. And then also just to think about herpes simplex. So what might make you consider a baby has herpes simplex infection causing their late onset, their early onset sepsis symptoms and signs?
So if mum, if there's a history of genital herpes in mum, so particularly with primary infection, then that might make you think that. Or if the baby develops lesions that are suspicious, so sort of lesions that look like herpes.
Yep, yeah, absolutely. Actually, it's most common that the most common presentation of herpes simplex is with without a history of maternal illness, and as it's a primary infection, it's often hidden and not necessarily recognised. But what about apart from lesions in the baby? What might a baby present with apart from sepsis-like syndrome that might make you think about?
Neonatal seizures.
Yep, seizures, absolutely. So we sometimes add acyclovir in babies that have got difficult to control seizures of unknown etiology, absolutely. And the other thing is a coagulopathy and a hepatitis or deranged liver function is in the context of a baby presenting with a sepsis-like illness must make you think of herpes. Okay. Any questions about early onset sepsis, antibiotics, and treatment? Okay, so most of our antibiotics, particularly our kind of longer courses of antibiotics, are due to late onset sepsis. And as we said earlier, most of our late onset sepsis is acquired within our neonatal unit, and it's very common. And it occurs in up to 25% of very low birth weight babies. I think we've made quite good strides actually across the world in reducing nosocomial infections with better line care and quality improvement projects to reduce nosocomial infections, but we've still got a long way to go. The most common two organisms we get here on our neonatal unit for late onset sepsis is coagulase negative staph and E. coli, although there are a lot of other bacteria also. Other gram positives, in addition to coagulase negative staph, we get a moderate amount of Staph aureus, fortunately enough, not very much MRSA, and Enterococcus. And in addition to E. coli, gram negatives might include Pseudomonas and other things that many of us have never heard of, like Routella, which is one of the gram negatives that we've had on the unit recently that Lydia Perez had in her chest. So it might present with sepsemia, but we also have had a recent baby with meningitis, and we're often thinking about whether or not babies have got ventilator-associated pneumonia and whether or not and how to treat it. So those are the kind of things we need to think about as far as what we're treating with late onset sepsis. So first line, we use flucloxacin gent here. I think most neonatal units are now going to these kind of simple antibiotics for first line in late onset sepsis. There are still, I think, neonatal units around the place that go straight in for vancomycin instead of for their gram-positive cover, and some units will use something a bit more broad spectrum than gentamicin as well. But fortunately here, we have very low amounts of gram negatives that are resistant to gentamicin. And gentamicin has been shown for many years not to drive resistance in the way that some other antibiotics do. And we've made a conscious decision to use flucloxacillin, even though we know that coagulase negative staph is the most common cause of late onset sepsis, and more or less none of our cons are sensitive to flucloxacillin. So if we know that a significant majority of our late onset sepsis is caused by coagulase negative staph, why don't we use vancomycin for a first line, do you think? Any takers?
I mean, is it sort of antibiotic stewardship, but also things like vancomycin are a bit more complicated to give, so you've got to measure levels, etc. But it's such a broad spectrum; it's not great to be giving it to lots of babies.
Yeah, I think that's the main thing really. It's around antimicrobial stewardship and resistance. I mean, it is our last line of attack against quite a lot of gram-positive organisms. So if we start bandying about vancomycin left, right, and centre, and we get vancomycin-resistant organisms, then that's going to be extremely challenging for us. It's also that coagulase negative staph tends to be a pretty indolent infection. So although I think you do get babies who die of severe coagulase negative staph infection, it usually takes a little while to get warmed up, and so you've usually got time to grow the organism and then change antibiotics without causing the baby too much problem. There is a concern just at the moment, actually. There's been an increase in incidence of Staph capitis infection in a number of units across England, actually, and in particular 2 units in London, GOS and King's, have had what they've considered to be outbreaks of Staph capitis in particular. And that does seem to behave in some babies, and maybe it's just some strains of Staph capitis tend to behave a bit more aggressively, and babies can get more unwell. We haven't experienced that here as far as we can see, but it's just something to also be aware of. There's actually a Public Health England investigation of going on looking at increased incidence of Staph capitis across the country. So it'll be interesting to see what they come up with as far as advice and policy that comes out of that. So we don't necessarily use flucloxacin gent as a blanket policy for late onset sepsis, obviously. Now, so just on the right-hand side of the screen, there are just some things to consider. So if a baby presents with what looks like some abdominal concerns, but you haven't gone quite as far as diagnosing NEC, you might choose to use amoxicillin instead of flucloxacillin as the first line. And if you are worried about NEC, triple antibiotic therapy is amoxicillin, gentamicin, and metronidazole. Does anyone know why we might choose amoxicillin instead of fluclox when you're dealing with the gut?
To cover enterococcus.
Sorry?
To cover enterococcus.
Enterococcus, absolutely right. Yeah. So the clue's in the name, enterococcus, and we do get a few enterococcal septicemias every year. So it's definitely something to be aware of. And the other thing to say is if a baby's been around the unit for a while, please don't ever start a course of antibiotics without going back through their microbiology, because if they, for example, have been colonized with a gentrin-resistant organism, then you should choose to start an antibiotic that will cover that organism. Usually, our gentrin-resistant organisms are sensitive to amikacin, so you don't necessarily need to go straight for something as blunderbuss as meropenem, for example. But it's important that we don't just do the knee jerk when babies are hooching with something that's going to be resistant to those organisms. Likewise, if a baby's colonized with MRSA, you wouldn't necessarily choose flucloxacillin as your first line. That's always worth thinking about. We've had a couple of babies die over the last 20 years since I've been here, where we've known about a resistant organism, but have not started antibiotics that is against that resistant organism. It's one of the reasons why it's really important when you have a resistant organism that you colonizing a baby, you make sure that it's in the critical care indices on badger, so that it's easy to find. Now, this is a bit of a wordy slide. Apologies, I've just basically cut and pasted it from the guidelines. So if you don't pick it all up, it's on CliniB, and it gives you an algorithm for to follow as far as choosing your antibiotics and what you do as far as stopping antibiotics or changing antibiotics. So a few headlines, and I'm not going to go through everything in detail. A few headlines really. Number one is if a baby's well and the infection markers aren't significant and the cultures are negative, then you have to stop antibiotics. And if and I've just noted on the right-hand side there that antimicrobial stewardship may not save the life of that baby, but it will save lives eventually, because there was an article in the BMJ recently which basically said, sorry, I'll come and find it. Thanks. Which basically said of the 55 antibiotics in the antibiotic pipeline, none of them are any good as far as research is concerned. So it's really important that we're careful about stopping antibiotics. So that's important. Coagulase negative staph, one positive coagulase negative staph culture does not equal con sepsis. Please always remember to repeat blood cultures. And if you've got, if your second blood culture is negative, then that strongly suggests that the first blood culture with cons in it was a contaminant. And so that once again, those are good reasons to potentially stop antibiotic courses if you've grown cons once and the baby remains well. And the other thing, I guess, is what might precipitate you to change antibiotics. As I said earlier, none of our cons are sensitive to flu clox. So if you do think it's con sepsis, then the baby you'll need to change the flu clox bank. And if babies have got gram-negative septicemia, then it's generally held that just giving gentamicin is not going to be adequate. So if a baby is extremely unwell and is on gentamicin and is presenting as if it's got gram-negative sepsis, then you will want to escalate. If the baby has clearly got a VAP and doesn't seem to be responding, then gentamicin doesn't penetrate well into various tissues, including the lung. So you may want to change the antibiotics to something that is better penetrating to the lung. VAP's very problematic, to be honest. It's really difficult to diagnose. Babies might not have a great inflammatory response. Obviously a baby with chronic lung disease, it's very difficult to assess whether there's got infective exacerbation. But it is worth considering changing antibiotics if the baby does appear to have a VAP and isn't responding. That's probably all I'm going to say, as we've had 15 minutes. Has anyone got any questions?
Tim, if a baby's come from somewhere like Lewisham springs to mind that uses amikacin, but not because they've grown a resistant organism, should we continue the amikacin, or do you usually switch them to our protocols if it's not a proven, it's not proven that they've grown a gent-resistant organism, for example?
So I did mean to mention that. Thank you for bringing that up. So Lewisham used amikacin and Woolwich use amikacin because they have a history of a significant amount of gent-resistant gram-negatives. And so they elected a few years ago, when they had a few outbreaks, to use amikacin as first line. And I think there's reasonable evidence that there's these gent-resistant organisms are circulating in the community. So the advice is, if they come from Lewisham and Woolwich on an amikacin, we should keep them on amikacin. We've had a number of babies, 2 babies, I think, that I recall in the last few years, that have come from Lewisham with NEC, and they have grown gent-resistant organisms in their blood cultures, but we've only found that out 24 hours after the babies have got here, because they've got cultured there and then transferred over. So yes, we would we should continue those babies on amikacin once they've got here, and then obviously once we've found out whether they're colonized because of our gram-negative screens that are done on admission, then we can potentially rationalize, or on subsequent antibiotic courses we can do something different. But we should keep amikacin going after they've when they first arrive.